Yes, ma'am.
Yeah, now you start.
Okay. Good evening, everyone. August is a very special month and it's very close to Jindal ma'am's heart. Why? Because we remember the good old days with the first IVF baby of Tri City, born in this month at Jindal IVF on 5th of August 1996. We have all gathered today here for another very important chapter in the field of ART, which is the workup of infertile male. So, male infertility, as you know, is very significant and it contributes to approximately 20% of the cases. Now, enlightening us today on this topic, we have with us Dr. Swati Verma. She's the senior consultant at Jindal IVF. Ma'am is associated with Jindal IVF for the past 20 years. I welcome you, ma'am. Let's start on this topic. And I request all of you, if you have any questions, please post them in the chat box. We'll take up the questions side by side.
Thank you, Geetika. So, am I audible?
Yes.
Yes, yes, ma'am.
Thank you. Thank you, everybody, for joining us. And after the success of Series 1 and Session 1 that covered the workup of female partner in the infertility, now we are back to elevate your knowledge to include this workup. This is basically for the workup of infertile male. And this is the program, as you know, just I would like to elaborate. This is the 1 hour session every fortnightly. Timings are 6 to 7 p.m. This is an interactive session on the practical day-to-day management of the cases of infertility. There are 4 series of 6 sessions each. Series 1 is basically to deal with the basics of infertility management. Series 2 includes the ovulation induction and the stimulation protocol. Series 3 is infertility management and the various diagnosis. Series 4 is basically ART, that includes the details of IVF. Then this is just enlisted program that includes the speakers and the topics which are covered in the session 1. Session 1 is workup of infertile female, then that we have done. Then comes the workup of infertile male. Then after this session is the genetics for the clinicians. Then comes the pre-IVF workup. Thereafter the menstrual cycle and the ART, and then before moving to the advanced course, the last thing is the basic embryology for the clinicians. So with this background, I would like to start my discussion today now, because it's very important to this topic is actually very much important, and because most of the time the male factor evaluation goes neglected. So that is what should not be there, and I would like to highlight its importance and the ways how it should be evaluated in a case of infertility. Because we know that infertility is a complex multifactorial disorder that includes both male and the female factors significantly, and the male factor solely causes infertility in up to 20% of the cases, and it contributes additional 20 to 40% of the cases in the infertility. But it's very I would say, as I have told, this area is often neglected. Despite being such a simple test of a semen analysis, almost 25 to 27% of the infertile male may not even be offered a basic semen analysis. This is because the females are usual care seeker of infertility treatment, and the perception that the infertility is a gynecological problem, it is not related to man much. And the misconception that if the man have some problem in their semen, then the ART can circumvent the male factor problems. So these are the things that why the male evaluation is often neglected. But it is very important to know that the evaluation of the male infertility may uncover many underlying serious medical problems, genetic problems, endocrine, and the mood disorders, or even the malignancy also. So this becomes a very, very important thing. And this gives us an opportunity to look into the window of health of a male person, because it is seen that 1 to 6% of the men who are evaluated for infertility, they are at risk of having some type of cancer in their lives, in their lifetime, even when they have a normal semen analysis. So this area should never remain ignored. This is very, very important thing. Along with the increase in the risk of the malignancy, they also have a higher risk for the endocrine and the metabolic disorders.
Swati, let me just interrupt you here. How often do you find uh, endocrine disorders, or what
Endocrine
endocrine disorders
disorders, ma'am,
in
are
your
very,
experience are
very
common?
common. I mean, these patients have very high incidences of abnormal blood sugar levels. Some of them have a full proven diabetes. Sometimes they take treatment or they don't take. Sometimes they are not even undergone a basic blood sugar level. That is important thing. Along with that, many of them have a high risk for the cardiovascular disorders, like they are obese, and but they don't have any problem. They have never been evaluated for anything. So many of them have a deranged lipid profile. Many of them have hypertensive, so they have never undergone any sort of investigation. I mean, the male partner is often neglected. Sometimes we just look the semen analysis report and the report is fine. Then in many cases the male partner don't even accompany with the wife, and many a times at many centers they don't have a basic weight, blood pressure, these kind of things. So we don't know. I mean, these kind of the things have most. These are the things which are neglected, and in our routine practice, we see almost 30 to 40% of the male who are obese, who have some abnormal blood sugar levels. Some of them are hypertensive, but not taking medication because they don't think that is important, and cholesterol levels are far behind the limit of the requirement. So I mean, these kind of things actually are there in a regular practice. Even when they have a normal, absolutely normal semen analysis, even then these kind of problems are there.
And ma'am, first of all, they won't accept that there is a problem with the male. Most of the couples, they come whenever they come for the first time, and when the problem is detected, first of all, they won't accept it. And how do we counsel such patients about the health, these associated risk factors which are there? How do we counsel them because they're not ready to accept it? So how do we accept? Jindal ma'am can share her experience in this. Ma'am, unmute.
It's difficult to convince them to get treatment for diabetes or hypertension, and it's difficult to convince them that despite normal semen examination, uh, these medical diseases still can have impact on fertility, and obesity, I think, has been recognized as a very important factor. So,
Yes, yes.
I mean, it's you have to tell them that like diabetes affects all the organs of the body. It can't spare testes and semen also, and the sperms are also floating in the medium which has high sugar. So they listen to you. It's not that at least they do start medicine and some diet. They do
Okay.
start.
Okay.
Excuse me, Swati, before you proceed further, I will like to change one word. It is not the infertile male, it is the subfertile male.
Okay, okay, sir. Okay. So so with this background, the key objectives in the
Mm.
male infertility evaluation is first of all to find a fertility treatment. Whether is there any potentially treatable cause, we treat it. Or if the problem is not treatable, but this can be managed with the ART, that is IUI or the IVF with the partner sample, partner sperms,
बूंदी बहुत महंगी होगी अब
or to detect the
बहुत
conditions
बहुत ही
where
किसी चक्कर
donor
में
insemination is the only possible option. The second thing is basically to detect the life and the health threatening conditions that may underlie the infertility, and they require a medical attention for the husband's health. Then the third thing is basically to identify the genetic problems that may affect the health of the offspring or the health of the male partner. So these are the basic objectives of evaluation of any male partner. Then comes how should we evaluate. First of all, any evaluation starts with the history taking. We must have a very good and the detailed history taking, and half of the problems can be identified while taking a history itself. And after history comes the basic semen analysis. This is the part, these two things, history taking and the semen analysis, are the part of the initial evaluation. If we find any significant factor in the any abnormality in the history, or any significant abnormality or the multiple semen parameters parameters are abnormal, then definitely we need to refer a patient for the expert, that is the urological expert, for the examination and the further detailed evaluation. So that detailed evaluation could be endocrine, urological, or the genetic evaluation, whatever things are required. Then I'll start with the history taking. That is very, very important in cases of male infertility, because we can rule out a lot of problems just by taking history taking. So we start with the age, occupation, religion, educational status, duration of infertility, prior paternity, or the previous reports which the patient is carrying with them. Then sexual and the reproductive history, medical and surgical history, drug and medications, social lifestyle, and the family history. So I'll start each of the factor in highlighting the importance of each of them one by one. So let's begin with the age. This is again very ignored area in the treatment of infertility. Generally, we give a lot of importance to the age of the female partner, that your oocytes are going to be poor quality. The number of eggs are going to decrease. AFC is going to decrease. AMH is reducing. But we in general do not highlight the importance of the male partner, but we should understand that male partners age is equally important, because it is seen that if the paternal age is more than 40 years, so the child born to these father, they have a very high risk of different type of malignancies and the other disorders like the achondroplasia, neuroblastoma, retinoblastoma, Down syndrome, Klinefelter, epilepsy, breast cancer, childhood leukemias, and the CNS tumors. So we should always include these points in our counseling and highlight the importance of advanced paternal age also. Then coming to the sexual and the reproductive history. This is very, very important, but most of time this is not even asked to the patient. They come for the infertility workup. We just ask them कोई problem तो नहीं है and the things are okay. We have to specifically ask each and every point in the history. So this is very, very important. Some patients may feel comfortable giving this history. Some patient may not be feel comfortable. We have to make them relax and ask them in a very good manner to ask about these problems. Should we take a detailed history of coital frequency, decreased libido, erectile dysfunction, premature or the delayed ejaculation, or the absence of ejaculation, because each of one has an important point, and this many of these could be a sign of testosterone deficiency. So never miss these points while you take your sexual and the reproductive history. Again, there could be some patients who have some psychological erectile dysfunction. Otherwise, everything is normal. But whenever ovulation day is there, when they know that this is the mid-cycle, they have to try for the pregnancy. Just out of the stress, they are not able to perform. This is again very important problem. Plus, sometimes infertility in men itself is a feeling of shame, guilt, anger, and sadness, and the frustration kind of things are there. So you have to make their environment comfortable, and then you ask them very politely about the problems. Maybe they will be open to you and they will give you a detailed history, and you can sort out their problems. Plus, this is a unique opportunity to assess the patient's mental condition, his emotional status, and the interpersonal relationship with a wife. That can also sort out many problems. And again, very important thing is basically to overlook the challenges like masturbation. Some cultural and the religious practices basically inhibit the man to give a semen sample just because the masturbation is not acceptable in their culture. So this is again very important thing to ask for that. And if we find any sort of problem is there, then definitely for their personal relationships, we can refer them to some psychologist or the relationship therapist.
Ma'am, here I would like to ask one question regarding the erectile dysfunction. If a patient comes with that, how important is it to elicit the role of vaginismus in this case? Because that can also be one of the reasons for the erectile dysfunction. The male partner is not able to tell clearly, and how do we like diagnose and its implications? So, if Dr. Jindal, ma'am, if you're there.
Yeah, I think in our experience, this is one very common presentation because the if a female partner has vaginismus, the male partner doesn't, they are not able to understand what's wrong, and they think that they have not been able to perform well. and slowly they also lose confidence, and it's anxiety, performance anxiety. They develop performance anxiety, and many times these patients present with erectile dysfunction. And when we examine the female partner, then obviously with her fear and everything, we know that she has vaginismus. And then it takes a lot of counseling for the couple, that what is the problem. And the one basic golden tip is, if masturbation is normal, then the whole nervous system, local system, everything is normal. So it's most of the times it is psychogenic. It can be in the male partner, it can be in the female partner, secondary to vaginismus in the female partner.
Okay.
Yes, this is very important thing ma'am has highlighted. Always ask for the history of vaginismus to the female partner, because sometimes this is just the loss of confidence while doing a performance from the male partner also, if the female has a vaginismus kind of problem. Then moving again to the medical history, the history of cryptorchidism, orchiopexy, history of testicular torsion, trauma, developmental or the pubertal delay, history of diabetes, hypertension, spinal cord injury, infection or the genitourinary tract, infections of genitourinary tract, then recent febrile illness. The infections and the recent febrile illness can also cause a temporary suppression of spermatogenesis, and when we can have a lower sperm count. So all these things should be asked in the history. Then comes the surgical history for orchiopexy and herniorrhaphy, that can cause iatrogenic obstruction, and again it can cause decrease in the semen volume and the count, and the absence of sperm in the semen. Then retrograde or the retroperitoneal and the pelvic surgery can cause anejaculation, then vasectomy or the scrotal surgery, then history of bladder and the prostate surgery. Again, these can cause the retrograde ejaculation. The family history of infertility to the brother is very important. Infertility to the not only the brother, even the cousin brothers is also very important. And the history of cystic fibrosis and androgen receptor deficiency is to be taken into the detail. Then comes the lifestyle factors: obesity, use of lubricants, hot tubs, sauna, tobacco, alcohol, marijuana, vaping, smoking, anabolic steroids, and excessive exercise. These all can suppress the temporarily spermatogenesis, so we can have problems with the sperm count and number. And the steroids causes basically suppression of testosterone on also. So we have other problems of erection and all these things also. Then the gonadotoxins exposure of radiation or the chemotherapy or the heavy metals or the pesticide exposure are there. Then history of medication is very, very important, because sometimes we don't ask in detail, and patient also don't know how much and what medications are they taking. They just say that they are taking treatment for infertility, they are taking treatment for hypertension, taking medicines for depression, but we exactly don't know what kind of medicines are they taking. But each of them has its own significance, and they can cause they can impair with the spermatogenesis, or many of them can interfere with the ejection or the erection of the penis. So these are the important factors we have to look into the history.
And I think important medicines, there are two medicines which are very important, and they, cause problems. One is testosterone. Many times, still patients with oligospermia, they are prescribed injections of testosterone, which is absolutely wrong, because that will suppress hypothalamus and patient will land up with azoospermia. But fortunately, that is reversible. The second is, these days men are very fond of gym and building their bodies. So anabolic steroids also are one of the major reasons that these patients may have uh, abuse, steroid abuse. We can say that, and land in hypogonadism, and they may not ever realize that what kind of damage they are doing.
Dr. Ritu, please mute. Dr. Ritu, please mute. Yeah, thank you.
So, as the ma'am was saying, that testosterone abuse are very, very common nowadays in the youngsters who are going into the gym, and this causes basically excessive, because of the excessive testosterone, it causes negative effect on the pituitary, and FSH and LH are suppressed, and that way they reduces the spermatogenesis. So this is, this is to be specifically asked, especially if somebody is having going into the gym or into the bodybuilding kind of ambitions. Then after history taking comes the basic investigation. So the basic investigations are recommended: basic semen analysis and the general blood test. General blood test, just to get a basic idea about the infection, the viral markers, and at least a blood sugar sample, hemoglobin, and if the wife HPLC, HbA2 is higher, then also ask for the HPLC of the husband also, just to rule out any risk of thalassemia to the baby. And what is not recommended is the extended or the advanced semen analysis in the first visit, unless until you find some severe problem in the semen analysis or other significant history related to that, the hormonal profile, the scrotal and the scrotal and the transrectal ultrasound, and the genetic evaluation. Should never be asked this investigation without a proper relevant significant history. Don't undergo a battery of the test without knowing the clinical history or the semen analysis report of the patient. Then I'll start with the basic semen analysis. Very important thing is to highlight how to ask the patient to give a semen sample. Many times patients are not comfortable in giving the sample in the laboratory. They don't have a proper collection room, and sometimes the sample gets spilled. They are not able to get a proper collection. Or they are not okay. Many of them cannot give the sample without their wives. So this is again very important thing. And how you should advise the patient to give a semen sample. So there should be abstinence of 2 to 7 days. Optimal is for 2 to 3 days. Sample collection should be by the masturbation into a wide mouth sterile container, preferably in a private room which is near to the lab, so that during transportation temperature is maintained. And analysis should begin to the 30 minutes and not more than 60 minutes of the collection. And during the time of transportation, temperature should be maintained. Ideally, it should be collected in the area around the laboratory, in the laboratory actually. And if it is an outside sample, we have to take precaution that during transportation, temperature should be maintained. Apart from masturbation, other alternative methods of the semen collection could be special type of sperm safe condoms, electroejaculation, vibroejaculation in the person who are not able to give the sample through the masturbation.
Swati, do you allow samples from outside in your hospital?
Actually, we don't allow, and legally also this is not allowed to, to accept the sample which have been collected outside. In our setup, we have a separate collection room, and we have to take we have to take specific precautions while asking the patient to give a sample. We have to provide a sterile container with the name and age, name of the wife, then her specific identity of the hospital number, whichever is given to. This has been mentioned, and we ask the patient to give a consent form. That person is giving a sample. So in that consent form, patient writes his name, wife name, CR number, plus then we give a recommendation form, what type of semen test is required, and these kind of formalities are always completed, and we never allow a person outside samples are not accepted. In a very, very rare situation where patients are not able to give the sample in the hospital premises, then we have to take a written consent actually, that they are not able to collect the sample despite repeated attempts, and they take the full responsibility of the semen they are providing us. So these kind of precautions should always be taken. Otherwise, it should not, this practice should not be encouraged actually. Then moving to the WHO semen lower reference range. This is actually WHO does not recommend the normal semen values. It just recommend the lower reference range, and lower reference range in the in the fertile men. Fertile men means the lower reference range is considered as fifth percentile of the semen values, those who have fathered a baby naturally. So this value does not mean that semen sample is normal and the infertility has been ruled out. First thing, we have to keep this point in our mind. Then comes they have provided some values, and these values, they have given each standards of volume, number, motility, morphology, vitality, everything. So we have to keep in mind what are the what are the lower limits, and according to that, we have to decide further how to proceed. Like according to the latest guideline in 2021, the semen volume is 1.4 and the total motile sperm number is 39. Motility is 42%, progressive motility is 30%, non-progressive is 1%, immotile sperms are 20%, vitality is 54%, and the normal form is 4% only. So apart from these indices of number, motility, and the morphology, the semen analysis also gives us insight of testicular and the endocrine function, and it also gives us information about the ductal patency. Then comes very important point regarding the semen analysis. As I have told earlier, single semen analysis cannot predict future fertility. At least there should be more than one semen analysis, ideally at a gap of 1 month. Individual semen parameters are very poor predictor of infertility. If the count is normal, the morphology is normal, or the motility is normal, then it doesn't mean fertility is there. It never. If the multiple parameters are abnormal, then obviously there is a increase in the risk of infertility. And very important to note that 15% of the infertile male have a normal value of WHO reference. Because as I have told you, WHO reference means only the lower limit of the fertile, of the semen sample of the fertile males. Plus, important thing is that if more than one abnormal parameter of semen is there, plus any other significant point in the history is there, then we have to refer the patient to the for the reproductive evaluation, and this is basically to the expert person. That could be a urologist. Then coming to the interpretation of any abnormal semen parameters.
Here, I think I would like to add here or clarify this point further, because many patients, they keep on, tracking the semen reports that previously it was 10 million, now it is 15 million, and now it is 20 million, and suddenly some other medicine was started and it fell to 5 million. So, one thing, it's very clear that the WHO values are just ranges of normal values. They do not distinguish between fertile and infertile men. It's again something like female fertility, where it's not possible to, detect the cause of fertility, or you cannot say that this poor sperm count is cause of infertility. It may contribute, but it may not be the cause of infertility, and many of such men may still be able to impregnate their wives. Only the absolute zero can be an azoospermic man. That there you can say that this is the cause of infertility. Otherwise, you just say that the chances of conceptions are low. And this tendency to follow the sperm samples, we get patients who have 20 semen samples done every month, or they keep on doing, and they take medicines and they see whether it's improved or not. Actually, the sperm semen samples are very variable. In a very old study, semen samples were done every day by men, and the variation ranged from 0 to something 100 million in many of these men. In everyday samples, this such variation was there. So it's not advised to track these samples के count अब कम हो गए हैं ज़्यादा हो गए. Only thing you have to see a broad range where they fall in the lower range or the middle range or the normal range.
Yes, ma'am.
One thing more, definitely this normal parameter does not predict whether there will be a natural fertility or not. But if these parameters are normal, probably you are more hopeful that ART will work.
Exactly, sir. Dr. Sanjeev has very rightly pointed out if these values are normal, then getting pregnant chances are higher. Then if we study the individual parameters, then the first thing is basically to look for the volume of the ejaculate. Ejaculate, basically, we look the three important things in the ejaculate. One is the volume, then fructose, and then the pH. So just to give a quick recap, that ejaculate volume, 2/3 of the volume is provided by the seminal vesicle and 1/3 is provided by the prostate, and less than 10% is contributed from the testicle itself and the accessory gland. And alkaline content and the fructose are provided by the seminal vesicles, and acidic contents are contributed by the prostate. And because from the embryological point of view, seminal vesicle and the vas deferens have the common embryology. So if there is vas deferens is absent, then most likely seminal vesicle would be hypoplastic or the absent. So we have to take these two things together. Then ejaculatory duct, anatomical point of view, this is just a recap that an ejaculatory duct is made by the duct from the vas deferens and the duct from the seminal vesicle. So if we keep these points in our mind, we can get a very good information from the semen analysis and reach to the information without doing an ultrasound. Like in cases of low volume ejaculate, where the ejaculate volume is less than 1.4. So this could be because of failure of emission or the incomplete collection of sample, because of the short abstinence period. It can also reduce the volume of ejaculate, or it could be because of the hypogonadism, because the androgens are required for the seminal vesicle and the prostate secretion. So hypogonadism again could be a reason for the low volume ejaculation. Then it could be because of the retrograde ejaculation. And the two important thing is that it could be because of the ejaculatory duct obstruction and the CABVD, that is the congenital absence of vas deferens, or along with that it could be associated with the absent or the hypoplastic seminal vesicles. So in cases of ejaculatory duct obstruction, because now we are not getting any content from the seminal vesicles, we are just getting the contents of prostate into the semen sample. So these kind of semen sample having low volume, acidic, they do not have any fructose, and there are no sperms. So this is the typical criteria or the typical features of a ejaculatory duct obstruction samples. Plus, how to differentiate between both the things, ejaculatory duct obstruction and the vas and the absence of vas. This is basically just by doing a clinical examination. If the vas is palpable, the reason is basically the ejaculatory duct obstruction. If the vas is palpable, then vas is palpable, then ejaculatory duct obstruction is there. And if the vas is not palpable, then this is likely a case of the absence of vas deferens. So we just need a evaluation of semen analysis plus a physical examination to reach a proper conclusion. Then comes the azoospermia. The azoospermia is defined as absence of sperm in ejaculate after testing twice on a high-speed centrifugation under the 400 rotation of 400. Sorry, under the 400 times magnification, and we
Please.
have along with the semen analysis report, we should also look into the palate. I mean, if sometimes the sperms are very less in number, they are not able to swim up. I am getting
I
disturbance in the
request Dr.
background.
Rashmi, please mute. Kindly mute your mic.
So sometimes the number of the sperms is so less that they are not able to move up into the after the preparation. So we have to look into the palate also. If there are no sperms in the analysis plus there are no sperms in the palate, then we label it as a azoospermia. And this could be a non-obstructive azoospermia or could be an obstructive azoospermia. So the non-obstructive azoospermia is because of the impaired sperm production due to the primary or the secondary testicular failure or because of the endocrinopathies. And obstructive azoospermia, as I have told you in the previous slide, this could be because of the congenital factors, CBAVD, or the other factors like trauma, infection, and post-surgery can also cause obstruction of ejaculatory duct. And the congenital reasons of ejaculatory duct obstructions are also there. Then coming to the oligozoospermia. Oligozoospermia means sperm concentration is less than 15 million per ml. And the
Swati, how many patients have you seen of congenital absence of vows? How common do you think this problem is?
Ma'am, it's not very rare actually, I can say. I mean, it looks like these congenital problems are rare and we do not face them, but these are there. And patient comes with obstructive azoospermia, and in actual practice, many of the doctors they don't recommend after getting a report of azoospermia. We don't ask the patient to go for a physical examination. In general, our practice is there. We get a report of azoospermia. We ask the patient to go for FSH, LH and then FSH, LH, and testosterone. So if these tests are normal, then then we think about that this could be because of the obstructive azoospermia or or the CBAVD. Then we ask the patient to we refer the patient to some urologist. I mean, this problem is not very rare actually. In our practice, I mean, 1 to 2 cases in a year, you can say we get these kind of patients.
I think Swati, 1 to 2 cases you may be getting, but if you see the total center,
Yeah, that
we
it may
would
be
be getting
always
at
10
least
to 15. It may
yeah,
be 10
one,
to 15 cases, yes.
yeah.
Minimum 10 to 15 cases in a year, we find it. Yeah.
Yes, and I think the most unfortunate part is that once anybody sees azoospermia, especially at the periphery, and they are just told that you go for donor sperm.
And ma'am, many patients they come with the report of testicular biopsy.
Yeah, that
In
is
such
also a very common practice actually. Once they say report of azoospermia, they just ask the patient to look whether, I mean, there is a only broad concept of two things in the periphery. If azoospermia is there, whether they just have to see whether sperms are there, they are forming or not. I mean, sort of practice. So they just they think that testicular biopsy is the most appropriate thing to confirm whether spermatogenesis is there or not. So, I mean, this is otherwise a very common practice in the periphery.
And obstructive azoospermia is such an easy thing to treat through IVF. I mean, you get such good number and good quality of sperms in obstructive azoospermia. I mean, with wonderful results in these patients.
Mm. And the procedure-wise retrieval of testicular sperm is not very difficult. This is a
Yeah.
very simple surgery because you get a lot of sperm collected into the epididymis, and the patient doesn't require any surgery or any anesthesia or anything. Just have to take out the sample through a syringe. I mean, it's just an aspiration sort of thing is there from the epididymis. From the epididymis, this is very simple thing and very easy procedure. Patient doesn't require a hospitalization also. And the good thing is that these sperms can be kept frozen for long time. Then coming to the oligozoospermia. Oligozoospermia means sperm concentration is less than 15 million per ml, and the severe oligozoospermia is when the sperm count is less than 5 million per ml. Then the causes of oligozoospermia, it could be because of the varicocele or the hypogonadism or the Y chromosome microdeletion. In all the cases, we need an endocrine and the genetic evaluation. to identify the reason of severe oligozoospermia. And this is not only the count of the sperm that we have to look into. There are two important things. One is the how much sperms are there in total ejaculate, and how much sperms are there in per ml of the sample. So that is very important thing to differentiate between our treatment planning and giving a patient of prognosis of getting pregnancy naturally. Then moving on to the sperm motility. Sperm motility, abnormal motility means asthenozoospermia. If the total motility is less than 42%, according to the lowest limit by the WHO, lowest fifth percentile by the WHO. So this abnormal motility could be because of the prolonged abstinence, varicocele, and the primary ciliary dyskinesia, infection, or the partial obstruction of ejaculatory duct, or because of the anti-sperm antibodies. And then comes the second thing is progressive motility. Progressive motility means less than 30% rapid motility. And this could be because of the mitochondrial dysfunction. And basically, the lower progressive motility is more effective index because it has been associated with the aneuploidy of the embryos, and it has also been associated with the sperm DNA fragmentation. So rather than taking account of total motility, this is always a good practice to look into the progressive motility. Then coming to the abnormal morphology. Abnormal morphology means teratozoospermia. So for morphology, we have to be very, very careful because very strict criteria have been proposed. That is the Kruger's criteria. And the normal morphology should have been more than 4% of the sperms. Then we need a very trained person or the CASA for evaluation of morphology, because it cannot be ruled out just by a simple laboratory microscope. As we see, the patient come with the semen reports, morphology normal 60%, morphology normal 80%. So it's not like that 80% of the sperms are actually normal. Actually, it's not like that. So for the morphology, we have to be very, very, we have a very strict criteria to document for the morphology, and very selective labs are there who document a strict criteria. And while looking a report of the semen analysis, we have to be very careful that if somebody is documenting 80% normal or 90% normal, most likely they have not did a proper analysis and they have not looked into the detail of morphology. Why I am so much stressing into the morphology? Because normal morphology is the best predictor of sperm function as comparison to the count and the motility. So this is actually a very important indicator. Plus, certain sperms morphological problem like globozoospermia and the necrozoospermia, they are very, very difficult to evaluate and very difficult to treat also. I mean, not only treatment, but very difficult to get pregnancy in these patients through IUI or through IVF. So morphology is, that is why it has a very important position. Then the causes of abnormal morphology are the varicocele, or may be associated with the primary and the secondary testicular failure. So we have some cases of globozoospermia with us and the necrozoospermia also with us. Although globozoospermia is considered as a very, very difficult problem to treat, actually the acrosome of the sperm head is absent. That is why there is a problem of fertilization. Generally, it is considered as a related to the genetic problems, and true globozoospermia is actually very difficult to identify and very difficult to treat. And I would like to get some comment from Dr. Sanjeev or Dr. Jindal to comment upon globozoospermia. I mean, from the embryology point, what they.
Okay. Diagnosis of globospermia is not difficult when you are using CASA, because CASA defines the head. What is the acrosome area? How is the size of the acrosome? It defines everything. So globospermia is not difficult to diagnose when you are reporting with CASA. It may be difficult when you are doing manually without staining. But if you are doing with staining under CASA, globulospermia is not difficult to. Regarding necrospermia, that even you can under a simple examining microscope, you can tell no sperm is moving, all sperms are dead, all sperms are something like that. Regarding treatment part, definitely IUI, etc., has no role in globulospermia because in absence of this defect, oocyte activation is not possible. So you have to do additional oocyte activation after ICSI. You have to put in artificial oocyte activation solution and all that. This is how you can manage cases of globulospermia, which you have to treat even the normal oocytes.
So after a evaluation of semen analysis, if you find any problem and multiple problems rather, and along with that, we have some important relevant points in the history, we have to refer the patient to a urologist. I would not like the points of examination here because this is not basically a primary our concern. And I just like to say that what they look into, they have to look into the problems related to testosterone deficiency like skin or the virilization or the gynecomastia, inguinal scars for any surgery, then evaluation of penis for hypospadiasis or epispadiasis, or the testicular volume, size, and presence or absence of vas and ejaculatory duct, and per rectal examination for getting idea about prostatic condition. Then coming to the varicocele, because these things are easily evaluated just by a simple physical examination, and we don't need ultrasound to diagnose the varicocele. And the varicocele which are diagnosed by the ultrasound, they generally do not impact the sperms, and so we don't need to give any treatment or the surgery for them. So we have to keep this thing in the mind that we don't need any ultrasound diagnosis for the varicocele. They are very common in the general population, and they are seen up to 40% of the patient with the infertility, and they cause decreases spermatogenesis because of the high oxidative stress. Surgery is only indicated when the palpable varicocele is associated with the abnormal semen parameters, or the varicocele have been associated with the azoospermia. So then we have a possibility that after correction, there is a very good possibility of return of sperm into the ejaculation, and the natural pregnancies can happen in these patients. Along with the reproductive benefits, the varicocele also has a health benefit because it increases the quality of the life because of the improved testosterone level, catch up testis growth, it corrects the size discrepancy, and it also gives relief from the pain because of the varicocele. Then coming to the endocrine evaluation. So in a routine evaluation, if we find any problem with the semen, we have to ask for the we have to ask for the endocrine evaluation. And the basic tests are the FSH and the total testosterone only. I mean, in the first visit, no other test beside the basic one, the FSH and the testosterone. And when we have to order them, this is when we have a history of decreased libido, erectile dysfunction, oligospermia, where the count is less than 10 million per ml, or the azoospermia, or the atrophic testis, or any finding which is suggestive of any endocrine abnormality, or the any relevant finding in the physical examination. So the LH levels after the FSH and LH report is there. Then after the FSH and the testosterone report is there, LH is indicated only when the testosterone levels are lesser. Normal testosterone levels are less. If the normal testosterone levels are more than 300. If the value is less than 300, we ask for the LH evaluation. Prolactin is indicated only in the men with the hypogonadotrophic hypogonadism, or there is a history of decreased libido. Estradiol is required in a man with non-obstructive azoospermia or the severe oligospermia, and to decide whether we can give them a medical management to improve spermatogenesis or not. Then a quick overview about the FSH and the LH. The normal levels of LH is 1.7 to 8.6 and FSH is 1.5 to 7.5. And FSH is recommended, as I have highlighted in the previous slide, it is recommended if the sperm count is less than 10 million per ml. High FSH means the severe damage of seminiferous tubule epithelium where the spermatogenesis takes place. So that is why in high FSH an indication of damage to the seminiferous tubule. LH and testosterones are recommended in suspected cases of hyperandrogenism and the erectile dysfunction. High LH and testosterone levels can be seen in the androgen insensitivity disorders. We have to take care them separately with an endocrinologist. Then low LH is seen in cases of exogenous testosterone administration because of the negative feedback mechanism to the pituitary, and also in cases of hypogonadotropic hypogonadism. Then comes the testosterone. Normal levels are more than 300 and up to 1000. Then free testosterone and bioactive testosterones are not recommended. We get a good idea about just by the getting total testosterone. High testosterone levels could be because of the endogenous high testosterone level are seen in cases of endogenous causes like CH, congenital adrenal hyperplasia, or the functional tumors, which could be adrenal and the testicular, and also in cases of androgen insensitivity syndromes, or it may be because of the exogenous use of testosterone. And the lower testosterone levels are seen in cases of hypergonadotropic hypogonadism. Klinefelter is the most common thing. Then transient low testosterone levels are seen in cases of systemic disease, medications, glucocorticoids, recreational drug, eating disorders, and the excessive exercise. Then coming to the E2 levels, the normal values are 10 to 42 picogram per ml. It's not only the E2 level give us information. We have to see E2 levels along with the testosterone. So in a way, we have to see testosterone to estradiol ratio. That is very important, and that is an indicator for the estrogen excess. And our target is basically to maintain the testosterone and TE ratio is more than 10 for the optimal spermatogenesis. If E2 level raises, that basically may be because of the aromatase excess syndrome or the estrogen secreting tumor or any occupational exposures and the exogenous sources or the like androgenic steroids. If E2 level rises, that means testosterone and estrogen ratio is lesser, so that basically leads to impaired spermatogenesis. So in that situation where the TE ratio is less than 10, aromatase inhibitors can be used to decrease the estrogen level, that boost up the testosterone level, and that can improve the spermatogenesis. So this is the principle behind giving the medical management to the patient where the spermatogenesis can be improved. The low E2 levels are seen commonly when the testosterone levels are lesser. Later on, the estrogen level also are reduced. So this is seen in cases of hypogonadotropic hypogonadism. Then comes the prolactin. This is again not recommended as a routine practice for everywhere. This is recommended if there is a problem of erectile dysfunction. Hyperprolactinemia is, I'm not going into the detail just because of the shorter time. I would just say, I would like to skip this slide actually. Then comes a basic evaluation based on the endocrinopathies.
Any
So
role of getting inhibin B done, like levels?
see, inhibin B and FSH go in a reverse way. I mean, just for inhibin B is a hormone that if the inhibin B level rises, that give us an indirect information of improving into the spermatogenesis. So inhibin B as such is not a first line investigation. We don't ask for inhibin B itself.
Additional.
I mean, this is only required to monitor a response of a medical treatment if spermatogenesis is improving or not, or before taking a patient for any testicular sperm retrieval procedure, whether we'll be able to get good number of sperms or not. Otherwise, inhibin B is not a test to be done on the primary at a primary level.
Okay.
I think inhibin B levels are important when patient is having history of some chemotherapy, some radiotherapy, because they also represent the function of germ cells. If you think patient was having previously spermatogenesis after chemotherapy or radiotherapy, there is azoospermia, and you want to check whether that spermatogenesis returns, probably these inhibin levels may guide you regarding this.
Okay, so should I cover this slide or this is?
I think simply we can highlight this that
I can
low.
just highlight that these are the three
हाँ,
things.
रही
One
है
is
घर पे।
LH, FSH, and
बोलो मैम कह रही है
testosterone.
वापस आओ, मैंने बोला 10 मिनट बाद फोन कर, बोलो मैम।
Please mute. Uh,
LH, FSH, and testosterone. If it is a case of severely impaired spermatogenesis, LH could be high or the low or the normal. FSH is high, and testosterone could be low or the normal. So based on this, we have to go for the E2 level evaluation. If the E2 levels are high, which means the TE ratio is now low, because obviously estrogen is high and the testosterone is low, then the ratio would be reversed. Then in
I think
this
I think we don't have to go into that detail. That is
okay,
confusing.
okay.
But basically, if high FSH is there, that indicates sperm damage,
Yes,
and
yes.
low FSH is there along
Because
with
of the
low
hypogonadotropic hypogonadism.
hypogonadism. And if normal testosterone, normal FSH is there, it may still have testicular damage and may still end up in and on testicular aspiration or micro TC. We may still maybe have difficulty in retrieving the sperms in these patients. So I think we can go by and large with testosterone and FSH. Other tests are for very detailed endocrine evaluation and treatment of some specific situations. I think we can skip that.
We can skip that. We can skip that. Then coming to the imaging in male infertility. So imaging also is important thing is it is not a replacement of physical examination. Trust is not required in a patient of CBAVD. This is only a diagnosis could be made on the physical examination. And scrotal ultrasound, if you look into this picture, it's very clear to understand that scrotal ultrasound is done in cases of is basically to look into the testicular volume, vascularity, varicocele, and the epididymal abnormalities. And the trans means rectal ultrasound is to basically look into the ejaculatory to look into the ductal system. So this is done basically to look into the ejaculatory duct pathology, dilated seminal vesicles, midline cells, cyst, or the dilated ejaculatory duct or the calcification. This also gives us information about the hypoplastic or the absent seminal vesicles or the seminal vesicle cyst and the prostatic abnormality. Important thing is here that in cases of congenital absence of vas deferens, we have to do ultrasound abdomen to rule out any associated renal agenesis. In cases of unilateral absence of vas, renal agenesis is very common, reported up to 25 to 75% of the cases. And in cases of bilateral absence of vas deferens, it is seen up to 10% of the cases. Then comes the genetics. So I would not cover here because this is a separate topic. In the very next class, I would just highlight that when the genetic testing is required. This is required in a sperm when the sperm count is less than 10 million, or the azoospermia or the testicular atrophy is there, or high FSH levels are there. And the other indications for genetic testing is RPL, RIF, or there is any family history of congenital malformations or the mental retardation in the family. So the rest will be covered in the next classes. I would just say there are three basic genetic testing which is done. One is the chromosomal analysis by the simple karyotype, which can give us an idea about the numerical and the structural defects on the chromosome. Chromosome means in the sex chromosome also, and also on the autosomes, plus give information on the sperm chromosome in the form of the sperm aneuploidy. And the genetic defects are X-linked or the Y or the related to Y chromosome or because of the cystic fibrosis. The X-linked abnormalities are Kallmann syndrome or the androgen insensitivity syndrome, and the Y chromosome defects are Y chromosome microdeletion. And the cystic fibrosis is associated in the cystic fibrosis we see association of CBA-VD. So I'll not go into the detail. This will be taken into the next class. So extended semen analysis, I would also like to skip, except that the sperm DNA fragmentation holds importance because because the sperm DNA is directly related to the sperm fertilization and its functional capacity. And the sperm DNA fragmentation index is required to be done into the cases of RPL if more than two ICSI failures are there, or in cases of repeated implantation failure. This is also recommended into the large varicocele, recurrent genitourinary tract infections, and in the advanced paternal age, poor lifestyle factors, prolonged use of antidepressants and the other medications. The referral value here are less than 15% fragmented DNA sperms, then it is considered as excellent fertility potential. It is, if it is between 15 to 25%, then it is considered as medium to good fertility index, and if it is more than 25 or 30%, then it is considered as a poor fertility potential. So this is actually important, and specific indications are required to undergo a sperm DNA fragmentation analysis. Then coming to the end, this is an algorithm which is given, I mean, by the
I think it's
ASRM.
a very complex
It's a
algorithm.
complex. Obviously,
Yeah.
I would not like to,
Oh,
I mean, analyze on this thing. This I have, I mean, put here just to look into the thing that the history and then hormone and then semen analysis. Then we have to go for the hormonal assessment. Then like, on the basis of hormonal assessment, we decide whether this is a case of obstructive or non-obstructive azoospermia. According to we decide. And in cases of non-obstructive azoospermia, we have to look into the genetic factor to avoid transmission of problem to the offspring. And in cases of abnormal hormone, we have to sort out the patient where we can give the medical treatment. So, I mean, this is just a representation of that thing. With that, I would like to conclude and with the words that simultaneous assessment of male and the female factor is very important. We have to refer the male partner to expert whenever it is required on the basis of semen analysis and the history, and a stepwise approach and the evaluation regarding the treatment option is basically a cornerstone of taking male infertility into account. So at the end, I have put some clinical situations also if we have some time. Gitika, do we have some time or have some questions?
anybody if wants to ask any question, you can ask or write in the chat box, or you can even unmute and ask yourself.
Any questions? Anyone? I think we can discuss the cases.
Okay, so now the case one situation is this is a case of primary infertility for 3 years. The female factor is 39, male is 34 years. Basic blood workup of the couple is normal. There is no female factor associated, no coital problem, and couple staying together since marriage. Semen count is 28 million sperm per ml, 15% progressive motility. Morphology is documented normal, 1 to 2 per cells, and 7 to 8 COH cycles with natural relations trial for pregnancy. So what should be the further evaluation? Anybody from the audience? I mean, what we have to look into specifically in this patient? Ma'am, would you comment upon, I mean, this is one of the very common situation. I mean, we have patients. This is actually one of the very common patient who come with this type of semen reports.
Yeah, basically this is a case of asthenospermia, right?
Yes. Yes.
And progressive motility itself is a very important parameter of sperm assessment. And in this case, I think first thing would be to do a repeat analysis.
Yeah, this is actually one semen report only, and just on the basis of one semen report, we cannot reach to any conclusion. So we need to get a repeat semen analysis. Along with that,
And you may have to get the total motile sperm count per ml in this patient, because that will give you some idea about more regarding fertility than simple count and motility. It's very difficult to calculate, by anybody that how many motile sperm would be there. Or maybe a swim up test would give you an idea how many sperms can be retrieved from such a sample. And that acts as a test in such situations. And varicocele needs to be ruled out, infection needs to be ruled out in these patients. And
So
maybe
repeat
systemic disease also like diabetes, hypertension, these also need to be ruled out. Alcoholism also is one common factor where such a semen sample may be there. Alcohol intake.
Yeah, yes. So these are
I
the
think definitely swimmable will help because this progressive motility of 15% is at room temperature or at lower temperature. We have to see the motility at 37 degrees. And many times motility definitely improves with when we keep the sample at 37 degrees. So as Madam Jindal earlier said, swim up we should do not only how many sperms are retrieved, but to how many sperms are actually moving fast now. That will also help.
Okay, so the basic, the management basically in this particular patient starts with getting a detailed history and go for a repeat semen analysis to reach any conclusion. So moving on to the next case, which is a primary infertility for 5 years. Female age is 33 years, male is 38 years old. The basic blood workup is normal. There's no female factor and multiple semen sample reports showing 5 to 10 millions per ml and the motility is 10 to 20% variable in the different reports. Morphology is documented normal. The couple had 4 failed IUI cycles. So what should be the line of management in this patient now? Ma'am,
I think state IVF fixing simple.
ma'am, would you?
This is actually I was going to raise this uh, last question from my side was what is the value of all this testing in the uh, era of ART. So I think the important point is that now the male factor is getting more and more attention. Now I think there is a lot of research going on to have a to how can natural fertility be restored uh, for males, and also how these sperm parameters affect ART outcome. Whether treatment of these factors would improve ART outcome, I think that is the next thing which is going to come. And I think a lot of research is also going on this, and this will slowly, I think, will improve. And here, I think, is a kind of medium sample, and ART should give excellent results in this patient.
Exactly. I think after having sperm semen report abnormal semen parameters with the 4 failed IUI cycles, the next step is to go for IVF.
We
Then
have a
moving to the
question, ma'am. We have a
okay.
question from Dr. Shalini. She's asking about the role of antioxidants and supplements available to improve the semen parameters of IVF.
ठीक है ये चलेगा ना मुझे मेरे को 10-11 के बाद दिखाना तो 19-20 को मैं दिखाऊंगा 20 तारीख को
Dr. Aditi, I request you to please. Thank you. Yes, ma'am.
Swati?
I think.
Are you asking the role of antioxidants? See, antioxidants are basically have a very selective indications for giving. For like if somebody is having high DNA fragmentation index or the ROS in the semen sample is very high, so these kind of samples have can they have some report that they can have a better sperm. They have a better sperm parameters after getting antioxidants. But as such, there is a lot of literature is having do not have very strongly support the use of antioxidant. Just that in case of unexplained infertility or very prolonged infertility, with the normal semen parameters. So if we have specific problems like DNA fragmentation is high, or the ROS is high, or somebody is having a very particular kind of lifestyle problems like obesity, some have systemic disease, diabetes, or then we can have some role of prescribing antioxidants. Otherwise, just on the basis that motility is low or the count is low, without getting a complete picture, overall picture of a clinical picture of a patient, the anti-sperms, antioxidants in general are not going to give you a very good result.
I think we have another question there. Achha, this is done.
This was the same thing. Yeah, this was the
Okay.
question.
Okay. I think we can close now. We are already 10 minutes over our time. If anybody has any question, they can just unmute and ask.
Any more questions from anyone?
I think.
Ma'am, just one more query. Good evening, ma'am.
Good evening.
Ma'am, if the DFI is high, are we preferring to do a TISA sample is preferred for IVF?
I think this is still like a controversial question because it was initially there. A lot of reports came that testicular sample may be a better sample than ejaculated sample in these cases. There are some reports which say that ejaculated sample is as good and DNA fragmentation does not matter. So sperm selection techniques like microfluidics, they may select normal. Uh, they may select
Dr. Sangeeta,
normal sperms. So you can uh, you can do microfluidics also, but I think if previous failures are there, my take would be to do a testicular sperm in these cases.
Thank you, ma'am.
So we should skip this situation. So I think, Geetika, do we have some more?
no more questions, ma'am, in the chat box. No questions.
So can we close the session now?
Ma'am, I request Dr. Jindal to give a closing statement on the topic, and then we can, I think,
Yeah, I
close.
think it's very important to investigate the male partner thoroughly, and it's not just the semen examination. And if we do find semen problems, we need to investigate them further. And many of the times you find such uh, uh, reasons which can be treated, and if not treated, at least they have implications for ART procedure to be planned and prognosis to be given, and then implications for the future generation. And genetic counseling is one of the very important component of that counseling, where couple is going for testicular sperm extraction.
Okay, ma'am. So I would.
With that, I think we'd like to close, and our next session, Dr. Sangeeta would be taking on genetics for clinicians, and she will again unravel some of the mysteries. Everybody's scared of genetics, and let's hope some clarification would be there in the next session.
Yeah, we'll
Over
see
to
you after 2 weeks. So I would now like to thank Dr. Swati and Dr. Jindal for sharing their clinical experiences, and Dr. Sanjeev also for sharing the insights. Beautifully, they have explained how to deal with the most common, mostly ignored topic, the male infertility, and wherever we lack. They have really helped us. So I would like to thank all of you and all the participants also. I would like to thank everyone. Thank you so much. Good evening.
Thank you, everybody. Thank you.
Thank you so much.
Thank you. Good night, everybody.
Good night.
I think we can close the session now. Bye, everybody. Have a nice day. Have a nice Rakhi. And thank you for joining us.
Thank you. Thank you, everybody, for joining.
Thank you.